morning and welcome to today's Surgery Grand Rounds. There is no commercial support. The planners have disclosed no relevant financial relationships, and our speaker today will disclose his relationships when he begins to present. You will receive a SurveyMonkey link after today's activity. If you're viewing online, we will list the evaluation link in the chat section. And if you're viewing this after the fact, you can find your evaluation link in the description section of the video. Also, if you are a surgeon and you are board certified and you would like NGHS to report your credits to the ABS, you will need to fill out the survey evaluation and give us permission to do that. It is my pleasure to introduce Holly Jones, who is our Director of Research here at Northeast Georgia Health System.
Thank you everyone for being here, and wanted to wish you a happy National Clinical Trials Day, which was actually celebrated on Monday, May 20th, nationally in the United States. We're celebrating the day of the very first clinical trial, which occurred on a ship, and a man tested the sailors on the ship to understand why they were getting scurvy. So kind of an interesting story there on Monday, May 20th, but really just a way to celebrate National Clinical Trials, and the fact that we also celebrate that here at Northeast Georgia Health System as a system. We are very excited to offer a number of clinical trials here, which you may be aware of. We can share more about that after the talk, but today I'd like to introduce our speaker, Dr. Maithel. And Dr. Maithel is a nationally and internationally recognized leader in surgical oncology. He's a board certified surgeon. Dr. Maithel is an expert in hepatobiliary surgery, including the Whipple procedure, pancreatoduodenectomy, and minimally invasive laparoscopic pancreatectomy. His clinical interests include surgical treatment of hepatobiliary tumors, cancer of the liver, bile ducts, and other gastrointestinal malignancies such as cancer of the pancreas, stomach, colon, and small intestine. He joined Emory Healthcare in 2009. He earned his medical degree at University of Chicago and at the Pritzker School of Medicine, graduating Alpha Omega Alpha, completed his internship and residency at Beth Israel Deaconess Medical Center of Harvard Medical School. Before joining Emory, Dr. Maithel completed a fellowship in both surgical oncology and hepatopancreatobiliary surgery at Memorial Sloan Kettering Cancer Center in New York. So he's currently serving as professor of the Division of Surgical Oncology, Department of Surgery at Emory University School of Medicine. He's the scientific director of the Emory Liver and Pancreas Center, director of Surgical Oncology Research Fellowship Program of Emory University School of Medicine as well. Dr. Maithel has authored over 500 scientific publications, and in addition, he serves as editor-in-chief of Surgical Oncology Insight on the editorial board of the Journal of Surgical Oncology and Annals of Surgical Oncology as well. So in addition, Dr. Maithel is the study chair and co-chair of 4 NCI-funded clinical trials and several investigator-initiated studies. He's also leader of 10 multi-institutional research consortiums that studied a variety of tumors. He also leads the active research program in the Division of Surgical Oncology, aimed at training postgraduate research fellows. As chair of the Gastrointestinal Surgery Working Group of the Eastern Cooperative Oncology Group of the American College of Radiology Imaging Network Cancer Center Research Group, Dr. Maithel evaluates the production of forward-looking clinical trials that focus on biomarker-driven cancer investigations. He's a member of the Discovery and Developmental Therapeutics Research Program at Winship Cancer Institute and leads their translational research program in Emory Division of Surgical Oncology, which focuses on identifying tumor-specific molecular biomarkers as predictors of outcome and chemotherapeutic response for tumors of a variety of tumors. So Dr. Maithel also uses diverse learning opportunities provided by his highly active laboratory to mentor medical students, general surgery residents, on research sabbatical, postgraduate research fellows. Interestingly, as well, Dr. Maithel provided the medical direction and voiceover narration for an app called The Surgical Anatomy of the Liver, intended for trainees. It's a 3D interactive app that allows users to mentally map the anatomy of the liver in ways that were never before possible with print illustration. So for those of you who are residents and fellows in the audience, Dr. Maithel's passion for research was clear as early as his residency, where he was awarded the Outstanding Resident Teaching Awards and first place winner of the annual Residence Research Competition at Harvard Medical School. Please join him immediately after this talk in Wilhite Conference Room today from 8 to 9 for further discussion of careers in surgical oncology and research following the grand rounds. And it's my pleasure today to welcome Dr. Maithel not only to Northeast Georgia Health System, but to the stage to present today on surgeons leading clinical trials through cooperation and collaboration. Let's welcome Dr. Maithel. Thank you.
Thank you very much, Holly. That was very nice. It's wonderful to be here. I just want to first of all thank you all for inviting me here. It's an honor to be here. It's great to see old friends. I think Pepper Brown was one of the first people I met when I got here in 2009 that Chris's dad introduced me to. So it's wonderful to be here. So I'm going to be talking about surgeons leading clinical trials. These are my disclosures. The outline, we'll touch upon the multi-institutional research collaborations with a focus on biliary tract cancers. Then I'll talk about how these trials kind of led to the NCTN cooperative groups and describe that process for you a little bit. Highlight the importance of patient advocacy groups and collaborating with industry through other types of cancers such as HCC, and then also gastric cancer, colorectal cancer, liver metastases, and pancreatic neuroendocrine tumors. In the spirit of National Clinical Trials Day and Week, I thought I would present a little bit of a snapshot into some of the things that are happening on the surgical side in all of these disease sites here. So one of my mentors and friends and teachers, Dr. Murray Brennan at Memorial Sloan Kettering, always said this to us as fellows: it's a privilege to make friends after the age of 30. And I will submit to you that conducting and completing clinical trials is very much dependent on good and trusting relationships with peers, partners, and patients. And it's all about people. And so in that spirit, about 12 years ago, I had torn my ACL playing soccer. I was at home in bed figuring out what to do. And I said, we should start establishing some research collaborations, working with friends. So this was the kind of 10-step outline that I took in terms of defining the idea or the disease that we were going to study, figure out the team, delegate authorship things ahead of time so there's no infighting between the group, project delegation after we had all the ideas submitted and deciding which institution was going to do which project, getting through the IRB, creating database templates, then getting on the data accrual process at each institution, with all of the data then coming back to the central institution that was running it. Most often it was Emory. The data analysis stage, and then we were off to the races with meeting submissions and publications. And this process really was an amazing process, and it was a lot of fun working with friends and colleagues all over the country, and it led to these 10 research collaborations that you can see here. We studied gastric cancer, biliary cancers, neuroendocrine sarcoma. You can see the whole gamut. And I'm very proud to say that the ones shown in blue here were all pretty much run out of Emory, either by myself or a colleague that we were mentoring through. And the other two were basically friends of mine that we helped run, one at Stanford, one at Ohio State. So it was really just a lot of fun, very productive, and it helped really set the stage for mentorship and sponsorship for lots of residents and medical students all over the country. And my peers, we all kind of grew together, and the boat just lifted together. So we'll focus a little bit on some biliary malignancies first to kind of show you where we went from a research standpoint and toward clinical trials. So if we first focus on gallbladder cancer, it's a rare disease, only about 8,500 gallbladder cancers annually in the US a year, of which about 60 to 50, 60, 70% are instantly discovered after a laparoscopic cholecystectomy. So the residents, you doing your lap chole, 1 out of every 150 or so will have an incidental cancer when the pathologists take a look at the specimen. And gallbladder cancer in general is associated with very poor survival, but the prognosis after surgery can be improved, but it's variable depending on stage. And so if you take someone with an incidental gallbladder cancer and you find that there is a cancer, the first question is, well, is the operation that we did, is that oncologically appropriate? And if the answer is yes, then there's no re-resection needed. If the answer is no, then usually we go on to re-resection, which involves a partial hepatectomy and a portal lymph node dissection, plus or minus a bile duct resection. And the basis of that comes from many population studies, and such as one of like this from the French group, where you can see that patients who underwent re-resection in green had an improved survival compared to patients who did not. And that improvement in survival persists across the different T stages, T2 and T3, although you can see the absolute survival, as expected, would be less for an advanced T stage. So in 2015, the HPBA put together a group where we basically kind of put together a consensus statement for gallbladder cancer. And we decided that patients with incidentally identified T1B, T2, or T3 disease in a cholecystectomy specimen should undergo re-resection unless this is contraindicated by advanced disease or poor performance status. So what's the rationale for re-resection? It's because there's a high incidence of residual disease, either microscopic disease in the lymph nodes or microscopic disease in the liver bed surrounding the gallbladder fossa. And if you look at this multi-institutional study that Tim Pollack ran, you can see that in the T2, T3, which comprises about 90% of what we see in this country, T1 is only about 10%, anywhere from 50 to 80% of the time there is residual disease, either in the liver bed or the lymph nodes. And the importance of having residual disease is illustrated by this study. As you can see that patients who underwent re-resection but had residual tumor in their specimen, shown in green, had much reduced survival compared to those that didn't. So eliminating residual disease is something we really are striving to. And you can see the importance even further here, where patients with T2 or T3 disease, so advanced T stage, but no residual disease on those two top curves, actually had improved survival compared to patients who had a lesser T stage but had residual disease in their specimen. So this importance is really, really important. And you can see that if you have residual disease, nearly half of the patients will recur within 1 year after we do that re-resection. So clearly, just a surgical approach for gallbladder cancer and even incidental gallbladder cancer, where we're picking it up relatively early, is not a viable treatment paradigm for patients. So hence comes in adjuvant therapy. We know patients are recurring, 50% of them almost within 1 year. Now, gemcitabine cisplatin has been the cornerstone and backbone of chemotherapy for biliary tract malignancies for a long time, since 2008, based on this paper from Juan Valle, where they compared gemcis to gemcitabine, and you can see that 11.7 months. Please remember that number, 11.7 months of a median survival. These are patients with advanced disease. So then came the BILCAP study, and this started 11 years prior to actually being published. And this is the time duration. You'll see it during the talk is how long these clinical trials take. But this was run out of the UK, the National Cancer Research Institute of the UK, and they basically grouped all biliary tract cancers, including cholangiocarcinoma, gallbladder cancer, and they randomized patients to observation versus 6 months of capecitabine. As 360 patients, 450 patients in the study. And you can see that gallbladder cancer only comprised about 18% of the cohort in each group. Otherwise, they were relatively matched, as you would expect for a randomized trial. And what they found in terms of recurrence-free survival, if you look at the intent to treat population on the left and the per protocol analysis, meaning all patients who actually received the drug, you can see there was a significant improvement in recurrence-free survival of about 8 months, 7-8 months, both in intention to treat and per protocol analysis. When you look at the overall survival, again, there's a clinical difference of about 15 months in the intent to treat, although you can see that p-value of 0.097 missed statistical significance. But again, on per protocol analysis, again, looking at patients who actually got the drug, there was a significant improvement in survival. So the capecitabine then kind of became one of the standards of care of adjuvant therapy. But again, if you look at kind of the subset analyses, looking at gallbladder cancer, you can see that that line basically goes across your midpoint. So really the effect of capecitabine in gallbladder cancer may not be that much, and you can see that the p-value driving may be more from distal cholangio and intrahepatic cholangio. Nevertheless, one of the current paradigms right now for incidental gallbladder cancer is upfront resection, followed by adjuvant chemotherapy. Many people will use capecitabine, but after the excitement of the trial kind of waned internationally, a lot of people still really cling on to gemcitabine and cisplatin as the backbone of chemotherapy, and people still use gemcis in the adjuvant setting for this population. So what are the challenges with how we're treating right now? Well, upfront resection, we know 20% of them are unresectable. We put a laparoscope in, we find metastatic disease. 50-80% of them have residual disease, as I highlighted to you, of whom about 40 to 50% will recur within 1 year. Adjuvant therapy, the data is not that great. A lot of people will tell you BILCAP was a negative trial based on the intent to treat analysis. It also was a all-comers trial. It doesn't really examine site by site. So you have the distal cholangio, intrahepatic cholangio, hilar, gallbladder all mixed together. I showed you the differences of the subset analyses. Some people still feel GemCis is the most convincing regimen, and chemo after surgery doesn't really address a lot of the challenges of re-resection. So we started thinking about this in our research groups and says it's time to really think our approach. And you'll see a kind of a common theme that I'm going to illustrate here is really going toward a neoadjuvant or a perioperative approach to patients with early stage resectable disease. But when we're thinking about trials in HPB oncology, these are rare diseases. I told you, gallbladder cancer, only about 8,500 to 10,000 a year in the country, compared to 300,000 breast cancers, 300,000 lung cancers. And patients with surgically resectable disease are even more rare. Only about a third of these patients are even going to see the operating room. So it's very difficult, if not impossible, to run meaningful single institution therapeutic trials. So hence entered the NCTN. This is the National Clinical Trials Network that is an engine run through the NCI and funded through the NCI. And contributing to the NCTN are all these different cooperative groups. So you can see ECOG, Children's Oncology Group, SWOG Alliance, NRG, the Canadian group, as well as NCORE, which is our community oncology programs. So I have been very involved with ECOG Akron for approximately the past 10 years, and this is where I kind of entered the NCTN process. Just to illustrate this process for you, because it's a very long process, you start in one of the cooperative groups, and in the cooperative groups, there's working groups. Each disease has a working group. So there's a hepatobiliary working group, pancreas working group, esophagogastric, colorectal. Trials are proposed there, vetted, kind of gone through, and these are composed of radiation oncologists, medical oncologists, surgical oncologists. So it's a multidisciplinary approach, which is the key to treating cancer. Once you go through the working group, then you move up to the committee level, go through the committee level, the trial gets a little bit more polished, then you apply for approval through the executive committee of ECOG Akron or SWOG or Alliance or whatever cooperative group you're in. Once you go through that, then you go on to the task force. The task force is then a membership of people who are representing all the different cooperative groups. So there's SWOG, Alliance, ECOG members in all of them. You go through the task force, again, you go through some iterations of the trial to really polish it. If you get endorsement, kind of approval from surveys and endorsement from the task force, then you submit on to the steering committee. And that's basically this bottom line. Steering committee and CTEP are kind of one and the same. And that's really the final stage where either you get approved, disapprove, or you get a pending where you have to revise, and then you get one shot at approval or disapproval. If you look at the whole process, only about a third of the trials ever get approved through this process. So 2/3 or 70% never make it through. So we first presented this idea of like, look, for gallbladder cancer, for incidental gallbladder cancer, we need to do a perioperative chemo approach. So we're really focusing on sequencing and neoadjuvant chemo. First went there in June 2016. We had lots of excitement about it, went through very quickly at surgeon pace. I don't know if there's any medical oncologists, well, Dr. Nash is here, but take surgeons to move things a little faster. So we went through the pace pretty quickly. We got executive approval in about 3 or 4 months, went on to the task force. The trial proposal was received very well. They actually asked us to do an international trial, and then the process began. Went through multiple iterations, a lot of politics between all cooperative groups, which I won't go into. But you have to really, one thing at the NCTN, when they're going to put $15 million into a national trial, they want to make sure this is going to get done. So you have to really demonstrate feasibility. And so, with gallbladder cancer being a rare study, we had to point out, that we have the support of high volume academic centers. We were going to use GemCis because everyone agreed that this is the chemo of choice for biliary cancers. And then this is where surgeons, again, running clinical trials at the national level, you really have to demonstrate national support. So I have a lot of network through the HPBA, went through the HPBA leadership, we had pledged support, but not only through Emory or my immediate community. Basically, we had to show the NCI that not only are we running through this Emory, but I had 42 support letters from all of those institutions that you see there, friends and colleagues who basically knew about the study, signed letters and saying, yes, we support this and we will enroll. So this was what we came up with. This is ultimately what's running right now nationally is opt-in, or ECOG Akron 2197. It's a sequencing study for incidental gallbladder cancer, where if you're diagnosed, you get all the usual upfront, go through the inclusion-exclusion criteria, and then ultimately patients are randomized in a 2-to-1 fashion to receive perioperative chemo. So 3 months of GemCis, followed by re-resection, followed by adjuvant GemCis, versus the control arm, which is upfront resection, and then 6 months of GemCis after. Our primary outcome is overall survival. It's a phase 2/3 study. It's currently enrolling nationally at around 300 centers across the United States. So again, to bring back to that process, to put it in perspective, initiated in June 2016. That's the first time I went to ECOG to really present this study. Approved in February of 2020 through all the manipulation, iterations, politics, waiting periods, all of that. And we were activated in December of 2020, pretty much right in the heart of COVID. And you can imagine accrual has been slow, especially during COVID, as the elective operations went down. A lot of lap choles weren't being done anymore. So if you don't do a lap chole, you can't diagnose an incident of gallbladder cancer. So patience is key in terms of running clinical trials, and surgeons are not known for their patience, but you have to really kind of develop a new timeline for yourself as you do clinical trials. And again, remember, cancer care is a multi-D effort. There's not just a surgical oncologist. You have medical oncologists, radiation oncologists, interventional radiologists, pathologists, gastroenterologists, all of these people working together and in concert to really develop the best treatment paradigm for a patient. But remember, the patient is at the center. And so these multidisciplinary networks and networking and friendships are paramount, but really that patient at the center is the key. So while I submit to you that patience is key to running trials, really patients are key to really succeeding with trials. And so hence enter patient advocacy groups. And patient advocacy groups like PanCan, Town, and this one, the Cholangiocarcinoma Foundation, are just incredible organizations and very, very important for us to partner with, be involved with, work with patients to really understand what patients want and how we can design trials that patients would be attracted to actually enroll and enlist in. So this Cholangiocarcinoma Foundation was started in 2006 by Stacy Lindsay, whose brother was diagnosed with intrahepatic cholangiocarcinoma in his 40s. And she has made it her life passion. She is an absolute angel. Made it her life passion to improve the care of cholangiocarcinoma, to educate patients, advocate for patients. And this foundation, which the first meeting was about 20 people, the last meeting we just had in April, there were about 1,000 people at this meeting. So it has grown, it's global, many, many people involved. So we'll shift from gallbladder cancer to intrahepatic cholangio. And you can see, even with resection of intrahepatic cholangio, which makes up only about a third of the patients that we see with cholangio, the 5-year survival is only 30%. So 70% of these patients are recurring and unfortunately succumbing to their disease. So we need to do better. So how do we identify high-risk features? How do we employ neoadjuvant therapy approaches to really not only eradicate micrometastatic disease prior to resection, but also improve our patient selection? Let's really figure out the patients that we're going to help with these major operations. And as the disease advances in molecular profiling and personalized therapy are happening in the advanced disease space, how do we bring it to the neoadjuvant space or perioperative space for patients with early resectable stage disease? Now, I will say, as I was discussing earlier, trials are first done in the metastatic setting. Usually it takes 4 years to accrue, 3 to 5 years of follow-up, 1 year to publication. So it can be a decade almost of 10 years lag of extrapolation of data to patients with resectable disease. Take, for example, pancreas cancer. The trial looking at FOLFIRINOX versus gemcitabine of Conroy, New England Journal of Medicine in 2011. GemNab trial by Von Hoff, New England Journal in 2013. It's currently 2024, and now we have the trial underway, which is the Alliance study through the cooperative group system. That's by two of my friends, Akhil Chawla and Christina Ferroni, are running this. It's a phase 3 study looking at perioperative FOLFIRINOX for resectable pancreas cancer versus adjuvant. But we are now 10 years after those data were presented for the metastatic setting and now are doing a perioperative study. So we need to study these concurrently. I think these lag of time is not fair to our patients with early stage resectable disease. So we go back to the GemCis I told you about with the median survival of 11.7 months. So my friend Rachna Shroff, who used to be at MD Anderson, now at University of Arizona, did this phase 2 study where she looked at a novel regimen, adding a third drug. So it was gemcitabine, nab-paclitaxel, and cisplatin, so GAP. It was she called it the GAP regimen. It was a single-arm phase 2 study of 60 patients where they all got this. And you can see here, when I told you that median overall survival was 11.7 months with GemCis, The median OS here was 19.2 months with a PFS of almost 12 months, response rates of 45%. And of the 60 patients enrolled, 12 of them actually were converted to resection, of them 2 who had a pathologic complete response. So this was a very exciting regimen and potentially thought to have much more efficacy for this disease. And the excitement of this phase 2 study, you can see again the response rates by this waterfall plot, with majority of them being to the right. But the excitement of that led her to run this study, the SWOG 1815, which is a randomized phase 3 study. So this study started accruing, and we saw this opportunity, again, through the Cholangiocarcinoma Foundation, working through these patient advocacy groups. I became friends with all of these medical oncologists around the country who were advocating for cholangiocarcinoma. And knowing that this regimen had efficacy, without waiting for this trial to be done, we said, look, we're going to study this to look at the feasibility and the potential efficacy, but really look at the feasibility and safety of giving this triplet regimen to patients with intrahepatic cholangio with high-risk features preoperatively. So we hypothesized that neoadjuvant therapy with the GAP regimen, or Gem-Cis nab-paclitaxel, would be feasible and potentially increase resectability rates, improve recurrence-free survival, and overall survival for patients with resectable but oncologically high-risk disease. And this was the NEO-GAP clinical trial that we designed. I did this with my friend from medical school, actually, Flavia Roca, who's now at Oregon Health Sciences. And it was the 4, you can see Emory, Anderson, Virginia Mason. He was at Virginia Mason at the time, and the Mayo Clinic. We just wanted to enroll 30 patients with these high-risk features, give them 4 cycles or 3 months of GAP, and then go on to surgery, with adjuvant therapy being dealer's choice based on the treatment team. How did we define oncologically high risk? Well, usually same things: large size, elevated T stage, multiple tumors, satellite lesions, vascular invasion, or suspicious lymph nodes. All things that are technically resectable, but again, are associated with high risk of early recurrence. So what we found, we enrolled 30 patients. You can see 2 patients actually progressed on therapy. 5 patients were actually found to have metastatic disease at the time of expiration, and 1 patient came off study because they wanted more chemotherapy prior to surgery. But as we define feasibility, is going through all of chemotherapy and surgery. And so you can see that from the table on the right and the top, 73% of this high-risk population completed all therapy. The toxicities, you can see, are relatively in line with aggressive chemotherapy regimens that we give patients. From the waterfall plot on your left, you can see the disease control rate was 90%. And importantly, again, part of the feasibility and safety was our surgical outcomes affected at all by giving this regimen preoperatively? I think the answer is no. We can see the hospital length of stay was 4. Only 9% had a perioperative complication, which was actually a minor complication. And these were high-risk tumors, greater than 5 centimeters. Many of them had lymph nodes. About a third of them were lymph node positive, as we see with cholangiocarcinoma, and 73% had an R0 resection. So we conclude that neoadjuvant therapy with gemcitabine cisplatin nab-paclitaxel is feasible and safe. So while we're doing that study, this is again the beauty of doing these concurrently. SWOG 1815 reports out at ASCO GI last year, and it's a negative study. So despite there being, again, an improvement of about 1.3 months, which in these types of trials is usually a significant value, but based on trial design, it's actually a negative study with a p-value of 0.65. And so the beauty of doing this concurrently was, had we waited till SWOG 1815 was done, there's no way we would have been able to run this study. So we would not have been able to run that regimen in the neoadjuvant setting. And now when you look at the subset analysis in SWOG 1815, you can see patients with locally advanced disease who got the regimen. So locally advanced disease, you could extrapolate to patients with high-risk resectable disease. You can see that GAP regimen had a median survival of 19 months versus 13.7 for patients who got Gem-Cis. So maybe there is still a signal of using this aggressive regimen in patients with high-risk disease, and there are still medical oncologists around the country who still use this despite the negative data of 1815. Let's take it one step further. We have molecular profiling. That's all the personalized therapy with cholangiocarcinoma, looking at targeted lesions. And cholangiocarcinoma is a very enriched disease that has all of these potential targetable lesions. And if we focus on FGFR2 fusions, these are very, very common being 5 to 15%, but common in intrahepatic cholangio. And just to show you one study called the Phoenix study that looked at a drug called futibatinib. This is a inhibitor of the FGFR2 fusions. And this study was done in patients, again, with metastatic disease, but importantly, who had progressed on first-line therapy. So you can see the number of prior systemic regimens. Half of them had already gone one line, but the other half had seen 2 or 3 lines of chemotherapy. And in general, as you progress on to chemotherapy, second, third, fourth line, the efficacy of the drugs get less and less. GemCis has a response rate of about 20 to 25%. So if you remember that number, 20 to 25%, in this population with an FGFR2 fusion, again, in second or third line, when given futibatinib, you can see the response rate was about 42%. And that waterfall plot, you can see as they all kind of lean toward the right, these patients are responding. The duration of response is good, with the median duration being 9.5 months, which is not something we see with standard cytotoxic chemo. And the PFS of 9 months with an OS of 20 months. For metastatic advanced disease cholangio, the overall survival of 20 months in the second or third line is quite remarkable. So again, why shouldn't we employ this type of strategy for patients with early stage resectable disease who may harbor these mutations as well? So again, working through the Cholangiocarcinoma Foundation, through the ICRN, which is the International Cholangiocarcinoma Research Network, I said, well, let's see if we can do this study preoperatively as well. So we wanted to focus on FGFR2 fusions, particularly because it's common in intrahepatic cholangio. You can do a biopsy and really assess that fusion with a biopsy. We talked about patient advocates, about in terms of how they inform trial design. We needed to assess, again, feasibility, because something like this requires the biopsy being done, sending it off to NGS to see, do you have the fusion? There's a delay of time there, about 2 or 3 weeks, to see if you have the fusion. How do you orchestrate a trial like this? So then we designed OPTIC, and I did this with Rachna Shroff, again, the person who was my friend who ran SWOG 1815 in that initial phase 2 trial of GAP. And we said, well, we'll get 40 patients at these 8 institutions, again, all friends and colleagues who are part of the Cholangiocarcinoma Foundation. We'll have resectable IHCC, do a biopsy, and patients informed us that while we're waiting for that biopsy to tell us whether or not they have an FGFR fusion, we got to give them 1 cycle of chemo, because patients are going to be very, very anxious to wait. So we give them 1 cycle of chemo, and then if they have the fusion, we were going to give them the inhibitor for 2 more months versus continue the chemo and then going on to resection. So very similar design as the NeoGAP study. So we had this ready to go, up and running. We had a company funded, everything was about to open, IRB was approved, and then the company pulled the drug. So this is one of the things. So the company decided from a company perspective, they were going to no longer make the drug for cholangiocarcinoma. So now we're still in this, waiting for the funding to approach another company. The other company who makes futibatinib is who I went to, is very interested, but again, it's all about the finances. So we're still waiting for the funding to run the study, but I have not given up, and we will keep pursuing it to eventually run this study to really advance the stage for patients with cholangio. One of the trials and tribulations of working with industry, but surgeons can work with industry as well. And medical oncologists work with industry a lot. We can do it too, particularly when you're running perioperative studies. Now, any cancer talk would not be complete without a talk on immunotherapy. And as you know, the TOPAZ-1 study was published a few years ago, looking at GemCis durvalumab, or a PD-1 inhibitor for advanced disease cholangiocarcinoma. It was also a positive study. You can see that tail end of the curve with an improvement in survival, improvement in progression-free survival. But importantly, you notice that at the initiation of the immunotherapy, and this is the one thing about immunotherapy, the response is not immediate. You can see those curves are superimposed. And then what happens with immunotherapy, as you prime the immune system, the tails start to separate, right? This is something we see in all immunotherapy trials. And again, you can see overall response rate about 26.7%, so not that different than what we see with GemCis alone in some of the other studies. But again, duration of response can be long, particularly for those few patients who have that tail end of the curve that you can see. But again, that initial 3 months, really not much of a difference. So when we think about using, this is the old slide deck here. When we think about using immunotherapy in the perioperative setting, we have to think about, okay, what are we aiming to do? Are we trying to get a reduction, or are we really trying to improve Are we really trying to improve the long-term outcomes? So again, this is another friend of mine, Hoptram Kao, who's at MD Anderson, who is really spearheading using perioperative immunotherapy for intrahepatic cholangiocarcinoma as well. And this study is running through the ETCN, which is the experimental arm of the NCTN. Small study, just looking at 27 patients where basically they're giving perioperative immunotherapy. So now we'll move on to hepatocellular carcinoma, and this is really well demonstrated in terms of the importance of surgeons working with industry. So if you look at the outcomes of resection with HCC, if you would do a resection within Milan criteria, it's about 37% 5-year survival. If you do it outside Milan criteria, of course, they don't do as well. And there's these high-risk features, again, that portend worse survival. However, there's a bimodal risk of recurrence, and that first mode of recurrence is usually based on the biology of the initial tumor that you're removing, such as size, tumor number, invasion. And then the second mode, which is happening 4 or 5 years later, is really related to the host liver, such as the etiology of cirrhosis or the etiology of HCC in the first place. So you could imagine it would be a second primary that's occurring. And looking at the survival rates shown in blue, the survival of patients who have early recurrence based on bad biology of a tumor are actually going to do worse, as you would expect. So the immunotherapy now from lots of the studies has really become the mainstay for HCC. And if you think about giving immunotherapy in the adjuvant versus neoadjuvant, you have to think about in terms of priming the immune system. So if you cut the tumor out on the top, and then you give the immunotherapy, there's not a lot of antigens for the immunotherapy to build and to respond to. So you can see you activate T cells, but maybe the response of T cells is not as robust. However, if you give the immunotherapy neoadjuvantly, with the tumor in place, you can see that potentially the response is a lot more robust. Take the tumor out, and then your activity is still present, and hence explain these kind of tail ends of the curves where the immune system is keeping the tumor at bay. So I Am Brave 150 was the first study that looked at this in the advanced disease setting. It was a positive study using atezo-bev, so atezolizumab and bevacizumab, compared to sorafenib, which was our standard of care. And then they did the I Am Brave 050 adjuvant study, which again randomized patients to active surveillance, which was our standard of care for HCC, versus a year of atezo-bev, again taking that metastatic regimen that they saw and applying it to the perioperative space or in the adjuvant space here. And the initial report shows a 13% improvement in their 1-year RFS, which met their primary endpoint. So this is still undergoing long-term follow-up, but has created a lot of excitement. And now giving atezo-bev in the adjuvant is something that we are doing for resected HCC. So now we're doing it adjuvant. So of course, the next question is, can we do it neoadjuvant preoperatively and really prime that immune system? This is the Neomorpheus platform that Genentech is running, and this is all public, so I can show this slide. But they have groups where they're giving atezo-bev. They're adding other drugs like TIGIT inhibitors and LAG-3 inhibitors. But they're really trying to develop a signal of, okay, what is the optimal regimen to apply to patients in the neoadjuvant fashion for patients with resectable disease? And that's my friend Adam Yope, who's the chief of surgeon at UT Southwestern. We were fellows together at Memorial. But again, so him and I are working with Genentech to design a global neoadjuvant study using this regimen. So we've met with the HPBA, met with the IHPBA, and we're really trying to put out a global study now for perioperative treatment for HCC. Again, really surgeons really driving the role for neoadjuvant and adjuvant studies. So all of this involvement with the NCTN, working with industry, working with patient advocacy groups, for me personally, was a great opportunity for mentorship and helping colleagues around the country. So we'll shift to gastric cancer. And this is the Stopgap 2 study. This is a phase 2/3 study, actually, that Maggie Sentil, who's the chief of surgeon at UC Irvine, proposed. And I've been helping her basically run through the process, as I illustrated to you, of the NCTN through ECOG. So thinking about gastric cancer now, there's about 26,000 gastric cancers a year. 30 to 50% of them present with unresectable peritoneal disease. And peritoneal carcinomatosis, while we do lots of cytoreduction procedures for appendiceal, for mesothelioma, for selective colorectal cancers, for gastric carcinomatosis, it's not very common. And you can see that with systemic therapy, even with targeted therapy with HER2 or Claudin 18.2 or immunotherapy, you can see those numbers of PFS and OS, where the PFS numbers are in that 7 to 10 month range, and the OS numbers are in that 11 to 18 month range, depending on whether you have the targeted therapy. Now, what about if you have peritoneal carcinomatosis? What about giving drugs that really target the peritoneum? Again, not talking about cytoreductive surgery and HIPEC, but giving chemotherapy to the peritoneum to really affect disease change and treatment in the peritoneum. So this is the concept of normothermic intraperitoneal chemotherapy that Dr. Sentel has really been advocating for and running a study at UC Irvine. And you can see from this Phoenix study from Japan, the median survival with IP chemo in that blue is 22 months for patients with gastric peritoneal carcinomatosis. And potentially, based on the pharmacokinetics of this, that when you give it when you give the paclitaxel and the IP, you can see that the concentration stays in the peritoneum much higher. So the exposure of the cancer to the drug is much higher compared to when you give it IV, shown on the bottom curve. So she's been running this stopgap 1 study at UCI, which is a phase 2 single-arm study. And she's already enrolled 20 patients, actually now 23 patients, but in short 2 years, which is just one institution, median PFS of 14 months. Compare that to the 7 and 10 months that I showed you with all the systemic therapies alone. And 7 of 20 of them have actually converted to go on to cytoreductive surgery due to good response. So this led to her proposing this, which is a randomized study. So she came to us, and I helped her through the ECOG process, through the NCTN. This has ultimately become a phase 2, phase 3 study, looking in, again, 2-to-1 fashion based on talking to patient advocates, of basically doing systemic chemotherapy alone versus systemic chemotherapy plus intraperitoneal chemotherapy. We just presented this for our final time at CTAP last week, and I expect this to be approved and funded probably within the week. It was overwhelmingly supported. And how does she do it again? It's all about surgical support from all over the country. She has these 30 high-volume peritoneal centers that have all pledged support and written letters that, yes, we agree with this trial and we will enroll patients. So let's flip to colorectal cancer liver metastases. There's also this study. It's this EA2235. This is another mentee of mine, Brett Ecker, who's at Rutgers. He finished at Memorial Sloan Kettering about 2 years ago. And he's looking at giving upfront chemotherapy for persistent ctDNA positive patients after resection of colorectal liver metastases. So if you look at patients this is a group of studies that have looked at the incidence of minimal residual disease or ctDNA positivity after resecting colorectal liver metastases. And if you look at the bottom here, about 40% are positive, and of those, only 25% will be disease-free at 1 year. So 75% of these patients are recurring at 1 year if they're MRD or ctDNA positive. And again, you can see here, it's nearly a 100% recurrence if you follow them long enough. Now, people often use FOLFOX. We know FOLFOX is usually the first line chemotherapy, but after they've had those 3 to 6 months of chemotherapy, in fact, after 3 months, the chance of clearing ctDNA, you can see, hits an asymptote right here at 80%, where if you continue to give FOLFOX, you're not going to really have much more benefit in terms of clearing that microscopic circulating tumor DNA, which eventually portends a recurrence of disease. So what are the other, after we've gone resistant to FOLFOX, what are the other lines? So irinotecan, we know, FOLFIRI, or TAS-102, or Lonsurf are options that we use, and they're data-driven in the metastatic setting. And then combining them, or TAZIRI, has also showed 2 improvements in PFS as well, combining Lonsurf or TAS with irinotecan. So there's 2 studies that recently came out, which is the Pegasus study that looked at converting ctDNA with FOLFIRI after FOLFOX failure, and they were able to convert it in 46% of the time. And then in the Intercept study, again, looking at just TAS-102 alone with ctDNA positive, showing that they cleared it 54% at 3 months, and it persisted in a third of patients at 6 months. So there is rationale for using these second and third line drugs earlier in the course of disease before radiographically visible disease when you just have ctDNA positive disease. So Dr. Ecker has hypothesized that combining these established second and third line therapies, moving them earlier in the course of disease treatment, that TAZIRI for persistent microscopic disease as defined by positive ctDNA after surgery and first line will improve recurrence-free survival. And so this is the trial that he has designed. a 2-to-1 again, 2-to-1, you'll see this 2-to-1 randomization theme occurring over and over again because this is what patients want. They want 2-to-1 chance of being randomized to the treatment arm where they get the novel therapy. They don't want to be on placebo or control arm. Placebo is long gone. Patients will not take placebo. So this is a trial that he's proposed. We have already gotten ECOG executive approval for this. We've gotten task force approval, and we just submitted to the steering committee. So we're in that final step as well for him to potentially run a national trial. Now, this is the old slide deck, unfortunately. So there's another trial I want to talk about, which is EA 2222, which has to do with hepatic arterial infusion pump. So we talked previously about these are patients who underwent resection of colorectal liver metastases. But what about patients who have unresectable colorectal liver metastases? Standard of care is chemotherapy, but there is hepatic arterial infusion pump therapy where we place a hepatic arterial infusion pump. I think Dr. Royale is trying to bring this program here as well, where you can actually deliver 400 times the dose of chemo directly to the liver, which based on all the data from Memorial Sloan Kettering, which is where the pump really kind of was born and raised for the last 45 years, would suggest that the efficacy of the drug when you're giving it in the artery directly to the liver is much more enhanced compared to IV. And there are data that suggests there's improved progression-free survival, improved overall survival, but that pump has never been tested in a randomized controlled trial in modern chemotherapy. So along with my colleague Mike Litsky, who's at Duke, and then my mentor at Memorial Sloan Kettering, Mike D'Angelica, and the medical oncologist Andrea Sursek, the four of us are leading EA 2222, which is also an open and actively accruing trial right now nationally. We just opened about a month and a half ago, which is randomizing patients with unresectable colorectal liver metastases to systemic versus systemic plus pump. We have 3 patients on right now. We're about to open this study at Emory. And they're about now, when there was only, pump was only being done about at one institution at Memorial Sloan Kettering. Now there are 55 institutions in the country who have a pump program. And so as those pump programs get more developed and more experienced, this trial will hopefully open up at more and more studies. It's at more and more centers. It's open at about 20 centers. And again, really on the support of the surgical support. We have something called the 8CRN, which is the research network for the pump. And there's about, like I said, 55 institutions that are supporting that. So I come back now to end this with the multi-institutional research collaborations. And now we'll focus a little bit on neuroendocrine. Dr. Rell had asked me to give a little bit of a slew and kind of a slide shot into all these different tumors. So neuroendocrine tumor study group, this was a study I did with my fellow Mohammed Zaidi, who actually just hired at Emory. He's completing his fellowship at Duke imminently, and then we'll be joining the Emory surgical oncology group in September. And we looked at pancreas neuroendocrine tumors, looking to develop a novel validated recurrence risk score to really find out who are these patients that we need to really watch closely for recurrence, and then also help to define surveillance strategies and potentially inform patients who would be candidates that we would think about for adjuvant therapy should we design an adjuvant therapy trial. So if you look at non-functional pancreas neuroendocrine tumors, you can see that there's lots of factors that we look at, like size, lymph node metastases, lymphovascular invasion, Ki-67, and you can see the different survivals there. And pancreas nets, they have a higher risk of recurrence compared to small intestine, other nets just in general. Other therapies are available, like PRRT, but PRRT is not really employed right now for early stage resectable disease. So his aim was to develop a prognostic risk score for disease recurrence for resected pancreas neuroendocrine tumors. So we used the power of the U.S. Neuroendocrine Tumor Study Group, again, a 10-institution study where we had tons of pancreas neuroendocrine resections. I actually combined with the Italian group, and we had 2,400 patients in the database. When we weeded out all the non-pancreas, non-metastatic, we had about 1,000 pancreas neuroendocrine tumors that were under resection between our collaboration and the Italian group. We divided them into a derivation cohort and a validation cohort, which you can see are very randomly designed. So they're basically superimposed outcomes of RFS and OS. So they're very matched groups. And we got to work first on the derivation group, and through our analysis using regression, we basically came up with this recurrence risk score, assigning points based on their regression odds ratios, looking at if they were symptomatic, size, lymph node positivity, and based on their Ki-67. And we developed a recurrence risk score of 0 to 10. And that risk, and when we apply that to the derivation cohort, you can see all the slew of things, but you can start seeing on the curve there how there's 3 groups forming. in terms of the lower things, and you can see the blue, green, and red. And then when we isolate that down, you can see that there's 0 to 2 points, 3 to 5, and 6 to 10. And if we clean it up a little bit, you can see these three very distinct groups based on the risk score that we designed in terms of their RFS and 2 years and 5 years. So informing again, maybe these patients in blue, you don't have to scan them every 3 to 6 months. Once a year, once every 2 years is probably fine because the recurrence rates are extraordinarily low. Cost savings to the healthcare system in general versus the patients in green and red, you need to watch a little bit closer. So then we validated it in our validation cohort, and again, exact same thing, which you would expect given that the cohorts are very similar. So this is, again, the beauty, and this is what makes me so excited about all these research collaborations that we ran for the first decade that I was doing this, is then that validation cohort and that risk score then comes back to the NCTN. And now, again, not through me, not through ECOG, but through my friends and colleagues through SWOG. And Sai Ahmad is a good friend of mine who's a surgical oncologist and head of the cancer center at the University of Cincinnati, gets involved with this trial through SWOG looking at adjuvant CAPE-TEM or capecitabine temozolomide for high-risk pancreatic neuroendocrine tumors. And if you look at the study design, we were very, very proud and happy to see this. Remember, my fellow's name was Mohammed Zaidi, and they basically used the Zaidi score, which I told them to change it to the U.S. Neuroendocrine Tumor Study Group score, but it's still called the Zaidi score. But that is an inclusion criteria now for a national clinical trial that's being used to look at the value of adjuvant therapy for high-risk resected pancreas neuroendocrine tumors. So again, showing how that all comes full circle, all these multi-institutional research collaborations that we did leading to national clinical trials in gastric and colorectal liver, in neuroendocrine, cholangio, gallbladder. So like I said, I come back to this. It's a privilege to make friends after the age of 30. These are just a few of the people that I've worked with over the years around the country, medical oncologists, surgeons, surgical oncologists, to help kind of design all of these trials and really lead this effort at a national scale. Could not do this alone. Of course, tons of teachers and mentors along the way from med school all the way through fellowship and currently now as an attending. All my friends and collaborators, like I said, running all these collaborations. Some of these collaborations were 20, 23 institutions strong. So a lot of people working together. And of course, my family supporting me while we did all of this. And, the fellowship program that I run, this is the engine, this is the workhorse of my fellows for the last 15 years. They've really done the lion's share of work for all those research collaborations that really laid the foundation for all of us and my colleagues as a whole to kind of get to the NCI level and really run national clinical trials. So with that, again, I thank you for the very kind invitation. I'm honored to be here and I'd be happy to take any questions.
If anybody has any questions, I can bring the microphone to you. Just raise your hand.
Thank you, Suzanne. Thank you, Dr. Maithel, for such an outstanding talk. And just wanted to share with the group that we do have your opt-in study open here at Northeast Georgia Health System. Dr. Royal serves as the principal investigator for that study.
Perfect.
So we have that open as well as the Alliance study, the pancreatic study that you mentioned. So thank you for being here and sharing such a wealth of knowledge about clinical trials. And thank you for sharing that about the team of collaborators that you're working with. So it's great insights into what it takes to run clinical trials and certainly the value for those patients that we serve every day. So appreciate you and all that you do.
Thank you.
Questions?
Thank you, Dr. Maithel. That was really thorough and great. And I think for the residents and other people in the room, it's hard to appreciate the amount of work that you've put into making these things happen for rare diseases. For decades, we just kind of accepted bad outcomes and only looked at metastatic disease, and surgeons were kind of left out of research when we were kind of the main people treating the earlier potentially curable disease population. So from my standpoint, thank you for setting up all these trials in the perioperative setting, and obviously all the collaborators like Flavio and whatnot who've worked to make cholangio and gallbladder cancers potentially better studied and better outcomes. So for the residents, obviously, you have the ability to lead research and really drive change in our disease states. You don't just have to be a technician when you graduate.
Yeah, absolutely. I think, I advocate at the national level that there should be a surgical oncologist involved in every neoadjuvant and adjuvant study, and also for locally advanced. There really should be, because it's a collaborative effort. And most of these, as you can see, there's always a medical oncologist involved, because these are all chemotherapy trials. These are not technical trials. They're all chemotherapy trials. And we have radiation trials. We have liver-directed therapy trials. There's all sorts of stuff that it obviously couldn't cover, but it's all about a collaborative effort toward cancer.
You talked about gallbladder cancer. You were trying to do, or you did, a neoadjuvant study. Is that correct?
Yeah, it's currently ongoing, which you actually have open
So-
here, yeah.
How are you making the preoperative diagnosis of gallbladder cancer?
So
Because most cholecystectomies are done in community hospitals.
Right, so the study is based on, it's only for incidentally diagnosed. So exactly as you said, the patient's undergone a lap chole for presumed benign stone disease. Pathologist finds the cancer, and then now at the diagnosis of an incidental diagnosed gallbladder cancer, that's where they could potentially enroll in the study, where they would be randomized to re-resection first or chemo prior to re-resection. So it's not at the chole
It's
stage,
not
it's
at
at
the
the
very
re-resection
beginning,
stage.
it's at the middle.
It's the oncologic operation, which is the liver resection, the lymph node dissection, plus or minus
Yeah,
the
that
bile
would
liposuction.
give you a preoperative diagnosis. That's what I was sitting here puzzling.
Right,
Thank
exactly. So in this country, because 2/3 are diagnosed incidentally, that's the main focus.
Dr. Maithel, thank you so much for the talk. Would you, really impressive work and everything that you've done. Would you elaborate and give some insight on how much time it takes for all the established data to percolate through the society and be really accepted as standard of care throughout the country? As we see, a lot of the communities still, I would say the practice patterns may be a step or two behind what is established as standard of care based on these trials. Would you give us some insight on what it takes in terms of timeline, effort to really allow this knowledge and standard of care to percolate through the community?
Yeah, no, great question. I think, I live in the academic world, and so all the data is it's handed to me, or we're part of it, we're making it. But you're right. I think this is something that industry struggles with as well. And we actually have, the HPBA now is partnered with industry partners to really try to get, like, for example, for the HCC, the data of atezo-bev in the adjuvant setting, that really still hasn't percolated, as you said. It's still, it's still in the early stages of design too, and so we don't know what the final results will be. But things like that in terms of immunotherapy. So it's things like this, like in the community where people like you are running trials, you're having, you're celebrating Clinical Trials Day, really getting the word out. And really kind of going to the community and people really going. So with webinars, looking on societies, it's up to the societies to really do that. So the HPBA, we ran a lot of webinars where we're trying to get the word out. But again, sometimes you end up preaching to the choir because the people who know about it are the ones attending the webinar. So how do you get it out there in the community? How do you get it to Oklahoma, to Iowa, to all of these places, Montana? It's slow. But I don't know. I think people also have to have a little bit of their own initiative to say, okay, what's coming out? Let me look at the, ASCO puts out a recap of ASCO or highlights of ASCO. Just take 30 minutes and just read the abstracts of the highlights of ASCO, and then it really kind of puts things at the forefront. But it's difficult. It's difficult.
Dr. Maithel, thank you very much for being here and sharing all your knowledge. As he alluded to earlier, we met 15 years ago.
Yeah.
And I will direct this to the residents. We met through a surgical society. And I would encourage residents, wherever your surgical career takes you in the future, become active in your local or state or international societies wherever your practice takes you. It will avail you to meet gentlemen such as Dr. Maithel, who has been a great resource for me throughout the years. So I would encourage you to seek the membership in those societies going forward. Shishir, thank you so much for being here.
Again, these are all trials that are underway. So none of these trials that I showed you today are complete. And a lot of them are phase 2 and they have to go on to phase 3. So the landscape evolves. And what the one unfortunate thing about clinical trials, like I said, from the BILCAP study, which was the adjuvant capecitabine study, just for the residents, John Primrose, who ran that study, is a good friend of mine. I asked him, he said it was 11 years from conception to finishing. And it took 8 years to accrue. And that's as simple as giving an oral chemotherapy drug. So this is another thing we need to do. And this is why the importance of collaboration, because it takes way too long to do these trials. And I do submit that the NCI, the regulatory demands that the NCI and the process, there's a lot of opportunity to streamline that, I think. We spend a lot of time talking in circles, and hence the patients and patients comment. But there's opportunity to streamline the process. And if we collaborate and we can actually create a process for global accrual. So opt-in, I'm actually trying to take global. I've been trying to open it in India. I've been trying to open it in Korea. I actually have collaborators in Korea that are trying to open it right now. Trying to open it in Europe, but then after COVID, the funding of the URTC got lost, so we couldn't do that. But if these rare diseases, if we can work globally, will accrue that much faster. That's why this is, again, the power of surgeons working with industry, because with the NCI, there's lots of regulatory demands and hurdles of working globally because of government regulations and contracts. But with industry, you can transcend all of that. So this HCC study that Adam and I are trying to do for perioperative immunotherapy for resectable HCC, we're doing with industry to see if we can make this global and actually accrue it very quickly. So there's benefits of working with advocacy groups, the NCI, industry, all of that. So I think it's good to be involved in all of it.
Absolutely. Thank you so much, Dr. Maithel. Let's thank our speaker once again. Thank you for being here.